This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi, this is a 70-year-old male patient who has pseudoexfoliation intumescent cataract, and at slit lamp examination the zonules look quite healthy. There is no evidence of any phacodonosis, but the pupil is moderately dilating and the lens is intumescent. The biometry does not show a very shallow antechamber, so I'm not expecting a very tense lens, but nevertheless I need to be careful for this patient. Under high magnification, the classical signs of pseudoexfoliation, that's sphincter atrophy and deposition of the exfoliation material on the antelens capsule, can be seen. The surgery is being done under topical anesthesia. The side ports are made. First, the air bubble is introduced, underneath which the intercameral preservative-free 1% xylocaine is instilled, followed by staining with trypan blue. Dispersive OVD is injected into the eye to deepen the chamber. A posterior limbal partial thickness groove is created, followed by a 2.8 mm incision. I am using cohesive OVD, that's sodium hyaluronate, under the pupil just to lift it up a little bit so that I can perform stretch pupilloplasty in this patient. So I'm using Y hooks to perform the stretch pupilloplasty. The idea of pushing the iris pupil a little bit away because the lens is quite swollen, so I don't want my instrument to touch the tense anterocapsule. So that's the reason by lifting up the iris we're a little bit away from the anterocapsule. I typically do the stretching along 4 axes, and immediately after stretching you can see the pupillary size is expanded very well. Time to perform the rhexis. One of the more common questions always asked about this, the instrument which I use to stabilize the globe during rhexis. This is called as the Banerjee's eye lock. It is designed by Dr. Banerjee from Mumbai, and it's available with Epsilon, I guess, and it's a nice tool to stabilize the globe. Or you can use any other instrument, but this is a cute little instrument to use it. The rhexis is around 4.5 mm. Since it's a mature cataract, I usually don't do hydrodissection per se, but I'm just checking the mobility of the nucleus. And once I'm certain about the nucleus is mobile, time to deal with the nucleus. An initial small trench is created, then shifting to the chop settings and using a burst form of longitudinal mode of phaco energy, the phaco tip is buried into the substance of the nucleus and a vertical chop is initiated. Care is to be taken that during lateral separation maneuvers, the chopper doesn't go and impinge the small rhexis margin. So we need to be conscious and aware of this, that the rhexis is slightly smaller, and in our enthusiasm to separate the fragments or divide them, sometimes the chopper can go and stretch the rhexis margin. So progressive chopping is continued until we have got multiple small fragments. Then each of these small fragments are pulled out of the bag and then emulsified at the level of the rhexis. The second heminucleus is being now divided into 2 smaller fragments, and then emulsification is being done in a very controlled manner to prevent any chatter. Now we are left with the last two pieces here. Note that the emulsification process is being done at the level of the rhexis margin, and the chopper is held in an oblique axis, and the two instruments form like a triangle, the phaco tip and the chopper, and this prevents the nuclear fragment from jetting out into the antechamber and coming anywhere near the vicinity of the cornea. So this ensures that the fragment is just moving around in the bag itself before completely getting emulsified. So using the chopper to prevent the fragment from jumping out is a good idea. So the nucleus fragments are all aspirated out. Few small tiny fragments will always be stuck at the side port. They need to be flushed out. Then is the routine stuff. I'm going to take care of the cortex. And once it is done, the lens has to be implanted into the bag. The rhexis is slightly smaller, so I would be planning to enlarge it once the intraocular lens is placed into the bag. Final time, I'm just trying to flush the posterior capsule with BSS just to clean it up a little bit. And then under the cover of irrigating fluid itself, the single piece hydrophobic lens is hydroimplanted into the bag. Now is the time to enlarge the rhexis. I'm just removing some remaining cortex here. Now to enlarge the rhexis, again I need to put in OVD here. I'm using a micro scissors from the side port to give a tangential cut, and then again using a small micro forceps through the side port itself, the rhexis is enlarged. The same process is repeated on the other side. Still there is some hidden cortex here, just going to aspirate it out. That's it, the case is done. The side ports are hydrated, and let's see how the things are on the next post-op day. To summarize, now this surgery was done entirely under topical anesthesia with a little bit of an intracameral anesthetic. The patient did not complain of any pain during the entire process. And the message here was, the pain sensitivity is very subjective. And this patient, we did all sorts of maneuvers, including pupil stretching, iris touching, and the patient absolutely did not have any complaint. And you need to understand that, apart from being an individual variation, iris usually touching is not going to cause severe pain. But whenever there is a chamber fluctuation, whenever there is a stretch on the ciliary body or the ocular coats, that's going to cause a lot of pain compared to just touching on the iris. So this was a case where it was clearly evident that even using Y hooks to stretch the pupil, the patient did not complain of any pain. Of course, it varies from patients to patients, but in this case, the entire surgery was done under topical anesthesia. We need to be mindful of the fact that some patients might have a slightly lesser threshold for pain and they could be complaining. So it would be wise on our part to add an adjuvant in the form of some sort of a subtenance block or something whenever the patient complains of pain. So that was it for this video. Thank you for watching and hope you found this helpful.